We will be talking about obsessive-compulsive disorder, with Karen Rousseau as our example. Part 4. Discussion. We will be discussing Karen's case in details now. Obsessive-compulsive disorder, OCD, is included in the Diagnostic and Statistical Manual of Mental Disorders, DSM-4-TR, APA, 2000, pages 462 to 463, under the general heading of anxiety disorders. It is defined by the following criteria. Criteria number 1. Either obsessions or compulsions. Obsessions as defined by A, B, C, and D. A. Recurrent and persistent thoughts, impulses, or images that are experienced, at some time during the disturbance, as intrusive and inappropriate, and that cause marked anxiety or distress. B. The thoughts, impulses, or images are not simply excessive worries about real-life problems. C. The person attempts to ignore or suppress such thoughts, impulses, or images, or to neutralize them with some other thought or action. D. The person recognizes that the obsessional thoughts, impulses, or images are a product of his or her own mind. Compulsions as defined by A and B. A. The person feels driven to perform repetitive behaviors, for example, hand-washing, ordering, checking, or mental acts, like praying, counting, repeating words silently, in response to an obsession, or according to rules that must be applied rigidly. B. The behaviors or mental acts are aimed at preventing or reducing distress or preventing some dreaded event or situation. However, these behaviors or mental acts either are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. Criteria number 2. At some point during the course of the disorder, the person has recognized that the obsessions or compulsions are excessive or unreasonable. Criteria number 3. The obsessions or compulsions cause marked distress, are time-consuming, take more than 1 hour a day, or significantly interfere with the person's normal routine, occupational, or academic, functioning, or usual social activities or relationships. The most common types of obsessions have been described by Rasmussen and Eisen, in 1992, who recorded the frequency of specific symptoms in a sample of more than 500 patients. The numbers in parentheses indicate the percentage of patients who exhibited each type of obsession. Most of the patients, 72%, had multiple obsessions. Fear of contamination, accounting for 50%. Defined as fear of exposure to stimuli such as dirt, germs, poison, or radiation. The person's concern may include fear that other people, as well as themselves, will become ill. Fear of contamination is most often coupled with compulsive hand-washing. Pathological doubt, accounting for 42%. An inclination to worry that something bad is going to happen because a task has not been completed correctly. People with this symptom often develop counting rituals that may include a complex system of good numbers and bad numbers. They may repeat certain actions a particular magical number of times, as in Karen's case. Somatic obsessions, accounting for 33%. The irrational, persistent fear of developing a serious life-threatening illness, often indistinguishable from hypochondriasis, meaning, fear of having some disease despite reassurance from a physician that the disease is not present. Need for symmetry, which accounts for 32%. An extreme need to have objects or events in a certain order or position, to do and undo certain motor actions in an exact fashion, or to have things exactly symmetric or evened up. Aggressive obsessions, in 31% of patients. They are recurrent, ghastly thoughts or images that the person has committed a violent or an inappropriately aggressive act. Sexual obsessions, found in 24% of patients. They refer to repeated, distressing thoughts about, or impulses to perform, inappropriate sexual behaviors. In addition to provoking anxiety, sexual and aggressive obsessions are associated with exaggerated feelings of shame and guilt. People with this symptom may seek constant reassurance from friends, or therapists, that they are not really capable of performing such actions. Compulsions represent patterns of ritualistic behavior and thinking that are usually performed in response to an obsession. Whereas obsessions lead to an increase in subjective anxiety, compulsions reduce the person's anxiety or discomfort. Compulsive behavior is designed to neutralize or to prevent discomfort or some dreaded event or situation. Most patients who seek treatment for obsessive symptoms also exhibit compulsive behaviors. Compulsive patients fall into two primary groups: cleaners and checkers. Cleaning and washing rituals are associated with fear of contact with contaminating objects. For example, a patient who is afraid of contamination by germs or bodily secretions may spend hours each day bathing or disinfecting his or her home. This ritualistic behavior restores the patient's sense of safety. Repetitive checking, on the other hand, is more often motivated by a fear of some catastrophic event. For example, a patient who experiences obsessive thoughts about gas explosions may engage in compulsive checking of the burners on a gas stove. Some other behaviors that take a repetitive form and are associated with either a decrease or increase in anxiety have also been considered compulsive in the popular media. These include problems such as gambling, drug addiction, and exhibitionism. However, some important distinctions can be made between these actions and truly compulsive behaviors. First, addictive behaviors involve a pleasure-seeking component that is absent in compulsive behaviors. Second, the anxiety that is associated with the performance of criminal activities, like stealing, is appropriate in light of social sanctions. Obsessive-compulsive patients experience anxiety that is inappropriate to the situation. OCD versus OCPD. Obsessive-compulsive disorder, OCD, should be distinguished from obsessive-compulsive personality disorder, OCPD. The latter does not involve specific ritualistic behaviors, it is intended to refer to a general personality style. People with an obsessive-compulsive personality are preoccupied with orderliness and perfectionism as well as mental and interpersonal control. They are inflexible and overly devoted to work to the point that they avoid leisure activities and ignore friendships. OCD versus phobias. The phobic disorders, like specific phobia, social phobia, and agoraphobia, are similar to obsessive-compulsive disorder because they involve severe anxiety and are characterized by behaviors that are designed to reduce that anxiety. Some obsessive-compulsive patients also display phobic avoidance of situations associated with anxiety about dirt or contamination. There are, however, some important differences between OCD and the phobic disorders. For example, phobic patients do not show the same tendency toward superstitious or magical thinking that is often characteristic of obsessive-compulsive patients, nor do they manifest compulsive symptoms. Also, for the phobic patient, the anxiety-inducing stimulus is unrelated to the content of any obsessions the patient may experience. Obsessive thoughts versus delusional beliefs. Obsessive thoughts should also be distinguished from delusional beliefs. Two criteria are important in this regard. First, patients with OCD try, often desperately, to resist their intrusive ideas, whereas delusional patients do not. Second, most OCD patients are ambivalent about their thoughts. They realize the essential absurdity of their obsessions and compulsions at the same time that they are preoccupied with them. Some OCD patients do have relatively poor insight regarding the senseless nature of their obsessions, but DSM-IV-TR requires for a diagnosis of OCD that, at some point during the course of the disorder, the person must recognize that the obsessions or compulsions are excessive or unreasonable. Depression is a common complication of OCD. 2 out of every 3 patients with OCD have experienced at least one episode of major depression at some point during their lives. The relationship between these phenomena is unclear. Sometimes compulsive symptoms appear before the onset of depression, in other cases, this relationship is reversed. The successful treatment or alleviation of depressive symptoms does not invariably lead to a reduction in the frequency of compulsive behaviors and vice versa. Although OCD was previously thought to be relatively rare, results from modern epidemiological studies suggest that milder forms of the disorder may affect between 2 and 3% of the general population at some point during their lives. Prevalence rates among untreated community residents must be interpreted with caution, however, because there is disagreement about the best assessment procedures to use in collecting information and the most appropriate diagnostic criteria. Data from England suggest that the true prevalence of OCD in the community may be closer to 1%. Relatively little information is available regarding conditions that set the stage for later development of OCD. Nevertheless, some interesting clues were provided in one classic study. Kringle, in 1970, reported the results of a 20-year follow-up assessment of 91 patients who had been hospitalized with obsessive-compulsive disorder. More than 80% of these patients had exhibited nervous symptoms as children. They had typically been raised in strict, puritanical homes. The average age of onset for compulsive symptoms in female patients was between 10 and 20 years, although most of the women did not seek professional help until some years later. More than half of the patients showed an acute onset of symptoms following a specific stressful event. Marital problems were common among compulsive patients. Prognosis. The prognosis for patients with OCD is mixed. Although the disorder can last many years, most patients do improve. One study conducted follow-up assessments with a group of patients 40 years after they had been treated in a hospital in Sweden. Nevertheless, the results suggest that many patients recover from OCD. At the time of the final follow-up, half of the patients had recovered from their disorder, defined as the absence of clinically relevant symptoms for at least 5 years. Another 30% showed some improvement, although they still experienced clinical symptoms. Approximately 20% of OCD patients do not improve following extended treatment. Karen was in many ways a typical OCD patient. She had, in fact, been raised in a strict, puritanical family setting. As a child, she was generally anxious and concerned with order and rituals. Since mid-adolescence, Karen had experienced difficulty with intrusive, repetitive ideas that she found distressing. These problems would come and go without apparent reason. She was also prone to serious depression. Karen's family background is also consistent with the literature on OCD. There is a relatively high incidence of psychiatric anomalies, particularly obsessional traits, anxious personalities, and mood disturbances, among the biological relatives of obsessive-compulsive patients. The similarity in behavior between many obsessive-compulsive patients and their parents probably reflects the influence of both genetic and environmental variables. In Karen's case, her mother's rigid, moralistic behavior may have had an important influence on the development of later symptoms. Karen's mother provided a salient model for her daughter's subsequent compulsive behavior. She also reinforced early tendencies towards such response patterns. In the next and final chapter of our case, we go over the theoretical perspectives and treatment implications of OCD. Check it out in the cards.